Hello. Hello, 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 hello. 1 2 3 1 2 3. Hello, hello, hello. Hello, hello, hello. Hello. 1 2 3. Mic check, mic check, mic check, mic check. Hello, 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 hello. Hello, 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 hello. ट्रांसफॉर्म अच्छा फिल्टर्स पे क्या है क्लोज फिल्टर्स पे जाके एडवांस्ड मास्क पे रीसेंटर और स्कैन सीन व्यू अच्छा फ्रेम चेक कट कर दो दिख रहा है अभी बराबर से फिल्टर्स वापस जाना पड़ेगा रीसेंटर मास्क अच्छा अब बराबर है क्या अच्छा
किसका तोड़ रहा है पेजेस हाँ किसका अच्छा अच्छा पेजेस फाड़े छे हाँ किस बुक फाड़े छे
अब बराबर है अब बराबर है अब बराबर है शिफ्ट अच्छा अब बराबर है ओके हेलो 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 1 2 3 1 2 3 माइक चेक माइक चेक माइक चेक आर वी रिकॉर्डिंग आर वी रिकॉर्डिंग and is everything getting recorded properly? Yes, everything is getting recorded properly and only so this is a test lecture on dyselectrolytemia, that is the imbalance in the electrolytes, which are the sodium, potassiums, the chlorides, magnesiums, calciums, phosphorus, phosphates. So this is a series on lectures which I am going to teach my students and fellow MBBS students. This lecture will be, I suppose that these lecture series would be easy to digest and understand the small nitty-gritties of day-to-day problems like electrolytes imbalances, specific diseases, and it would be helping my students, my DNB students, as well as fellow MBBS students, teachers, and colleagues to understand certain conditions and certain diseases. And this is my attempt to explain uh, the conditions as well as the diseases in as simple way as possible. So without taking much time, I think I should start the lecture. So today we're gonna learn about hyponatremia and hypernatremia, and uh, because this is a very varied, this is a very huge topic. We have to set certain goals to achieve maximum amount of knowledge, to get maximum amount of knowledge within a certain specific period of time. We have to set certain time limit, because nowadays, as you know, the coming generations and the current generation, is not understand. I sorry to say, not understanding is having that he is not having the patience. Uh, this is the Instagram or Reels generation or the YouTube Shorts generation. So uh, the generation is not having the patience to keep pace with the teaching style. My teaching style, as such, is maybe people may call it medium, not fast, not too fast, not too slow. So, for that, I am trying to keep my lecture as short as possible. At the same time, I would like to teach. I would like to teach as much as possible in that short span of time. So for that, we need to define our goals. What are the goals that we gonna achieve by learning this by listening to and listening and watching this lecture? We will define hyponatremia and hypernatremia. We will understand how sodium and water balance works in the body. We'll know common causes of both hypo and hypernatremia and will diagnose these two conditions using simple lab tests. We'll learn basic management and safe correction rates, and we will also remember important complications. So these are the 6 points that we are going to learn in this lecture. So most important is what is the basic concept about sodium and how does it affect our system or our circulation. So what does serum sodium tell us? Serum sodium shows the balance between water and sodium in the body. It is simple. Serum sodium shows the balance between water and sodium in the body, not just the total amount of sodium. Think of it like this way: too much of water is sodium looking low, too much of water, sodium goes down, and too little water, sodium goes high. So, too much of water, sodium goes down, that is hyponatremia, and too little of water, that is a specific case will be a case of a dehydration. Sodium will look high, and that is called as hypernatremia. So, sodium changes are mostly water problems. Water ऊपर नीचे हुआ, then sodium will go down or up according to the water levels of our body. So, what are the normal? First, we should know what are the normal levels of sodium in our body, and these are the normal sodium levels are 135 to 145 milliequivalents per liter. So, if you define hyponatremia, it is said to be less than 135 milliequivalents per liter, and hypernatremia is defined as sodium above 145 milliequivalents per liter. So, how the body controls sodium and water? Now, these three key players help us to control sodium levels in our body. The first key player is our brain's ability to detect thirst. So, thirst is the most important key player that tells us to drink water. Whenever we are thirsty, that itself suggests that our water levels are going down, or our water levels have already gone down, and the reverse is inverse is true for the sodium levels. When the water levels in our body go down, the sodium levels of our body go up, whereas when the water levels of our body go up, the sodium levels of our body go down. So thirst tells us that our sodium level has gone up and we need to drink little amount of water to stabilize or normalize the sodium levels of our body. ADH, that is the antidiuretic hormone or vasopressin, makes kidneys retain water. Now, kidneys have to be governed by certain hormone or some signals. What are those signals? Those signals are nothing but hormones, which is called as vasopressin or ADH, that is antidiuretic hormone. What does antidiuretic mean? Anti means opposite, diuresis means to produce or to flow or to produce water. So anti diuresis means to stop preventing flow of water. So that makes kidneys retain water. If you're not producing and not throwing out water, water retention happens. Kidneys, the third most important factor is kidneys. The kidneys decide how much water and salt has to be retained or thrown out of the body. So three factors are very important. First is thirst. When we are thirsty, that itself suggests the water levels have gone down and sodium levels have gone up. Then second is the hormone which is called as ADH. It controls the kidney and via the kidney controls the flow of water out of the kidney. And third is kidneys itself. They retain or throw water according to our water and sodium levels. So now coming to the next point is when sodium is high, ADH makes kidneys hold water. What does this mean? When sodium levels are high, ADH, that is anti-diuretic hormone, makes kidneys hold water. Why does our system want to hold water more? Because sodium level is high. So to stabilize and normalize sodium level, what will our brain send to the kidneys? A hormone which is called as ADH. ADH will tell kidneys that भाई बहुत sodium level ज़्यादा है, we need to dilute this sodium level. So what do? You stop throwing water away and retain water. When sodium level is low, what will ADH do? ADH is suppressed by the brain, and that way you pee a lot of water. Alright, then coming to the next point, that is talking about hyponatremia, that is low sodium. Hypo means low, hyper means high. Hyponatremia is low sodium in our body or circulation. So causes might be of three types or three groups. One might be euvolemic, यानी कि normal volume of water. Hypovolemic, that means water is less, salt loss is more. And hypervolemic, that is water is more or water is overloaded in our system. What is the volume status? In a case of hypovolemic hyponatremia, the blood pressure is on the lower side, but the mouth is dry because of dehydration. We are talking about hyponatremia. Alright, hyponatremia along with hypovolemia, that means volume has gone down and sodium is also gone down. So sodium has gone down. Remember that sodium is a very important electrolyte which controls our blood pressure. Why do doctors advise low sodium or low salt diet in a case of a blood pressure patient? Because sodium is inherently responsible for high blood pressure. So if you stop taking excessive salt in your diet, your blood pressure is going to naturally go down by at least 5 to 6 millimeters of mercury. So here hypovolemic, because water is gone down and there is salt loss in the form of hyponatremia, the blood pressure will go down, and because water is also lost, it will exhibit as dry mouth, सूखा हो जाता है मुंह. So what are the common causes of hypovolemic hyponatremia? One is vomiting. You're vomiting fluid out. Diarrhea. You're losing important fluids and electrolytes through your rectum, through your sigmoid colon because of diarrhea. Loose motions. Diuretics. Diuretics are nothing but these are the medicines which act on the kidney to throw out sodium, potassium, chloride. These are specifically used in certain cases of kidney disorders or certain cases of high blood pressure. Burns. Why burns will cause hypovolemic hyponatremia? Burns will expose the inner side or inner surface of the skin. Skin is a natural barrier for evaporation. It also helps evaporation, but it's also a barrier for important electrolytes to be maintained inside our system, inside our body. But if the skin is lost, the outer portion of the skin is lost, everything gets evaporated at a faster rate. So water will be lost because it is exposed to the environment. Sodium will be lost because it is exposed to the environment, and that will cause hypovolemic hyponatremia. What about Addison's disease? Addison's is lack of certain hormones which are responsible for retaining sodium. So Addison disease itself may cause low blood pressure and loss of volume of water. Then euvolemic normal body water, that is normal volume body water with hyponatremia, where their volume of water is normal, and so we will see no edema. What is edema? Swelling of the body, swelling of the lower legs or the thighs or the shins, and swelling of the face. So there won't be any edema as such. The volume status will appear normal. And which are the conditions that we see such kind of a status? We'll see in SIADH, inappropriately excessive ADH hormone, hypothyroidism, and adrenal insufficiency. All right. Then hypervolemic, that is water overload, is seen in cases of heart failure, cirrhosis, and nephrotic syndrome. अभी हुआ क्या? अच्छा ठीक चल रहा है क्या बराबर से? फ्रेम्स लॉस्ट, स्किप्ड फ्रेम्स नहीं है इतना, इनएक्टिव रिकॉर्डिंग इज इनएक्टिव, ड्रॉप्ड फ्रेम्स तो बिल्कुल नहीं है, सही है, अच्छा है, नॉट बैड. देखूँ यार क्या है. So coming to this point, hypervolemic hyponatremia, where water is overloaded, the system is overloaded with water, and that will cause edema and ascites. Ascites, but nothing but the accumulation of water or fluid inside the abdomen, peritoneal cavity, and that is seen in heart failure patients and cirrhosis and nephrotic syndrome. So what are the symptoms of hyponatremia? Hyponatremia will present with cases with symptoms like nausea, headache, and tiredness. Moderate kind of hyponatremia will present with confusion, vomiting, and severe kind of hyponatremia will present with seizures and coma. So if you see, most of these symptoms are related somehow to our brain, and that's why I always say that sodium is mostly related to CNS symptoms. That means the sodium problems will show as CNS problems or CNS symptoms, and that's why I have written down. This is not my nomenclature or my mnemonic, but I have learned it from somewhere. Sodium is equal to CNS. Sodium CNS. How it is sounding? So CNS. Sodium is connected to CNS. Alright. But why? Why does these symptoms happen? Because the brain cells, they swell when water moves into them. Brain cells and our body cells are they act similar. So water, if it increases or decreases in the cells, the brain cells will either swell or they will decrease in size. They will increase in size because of increased water overload, or they will decrease in size because of decreased water seepage out of the cells. So here what happens is the brain cells will swell when water moves into them. All right. Simple approach to diagnosis. The how do you diagnose such cases of hyponatremia? We need to confirm it's true, whether it is true hyponatremia. That means we need to first check whether we are dealing with hypoglycemia, that is decreased sugar, and lipids also, that is hypolipidemia, to rule out lab errors. All right. Then we'll have to assess volume status, that is signs of dehydration or fluid overload. And then we'll have to check urine concentration, that is called as urine osmolality, and urine sodium, whether the urine is throwing more or less amount of water. This helps us to find the cause. Now, if the urine is dilute, that means the osmolality or the concentration of urine is less than 100, then it suggests that water intake has increased. Alright, and if the urine is concentrated, that is the osmolality of urine is more than 100, that suggests that our central nervous system, that is ADH hormone, which is produced by the brain, is active, and it is actively producing and acting upon the kidneys to stop the kidneys from and to prevent the kidneys, to stop the kidneys from throwing out the water, which is seen in SIADH. What is SIADH? Syndrome of inappropriate secretion of ADH hormone. That means ADH hormone inappropriately, that means excessively secreted by certain tumors or certain conditions by the brain. And hypovolemia, because water is lost because of diarrhea or vomiting or burns. So water is lost, and that causes urine to concentrate. Now, how do you treat hyponatremia? That is the next point that we are going to discuss. I hope you have understood. If you have not understood anything, or if you have any questions, please comment down below. I will try to explain it in my next lecture. If patient has seizures or coma, that is a severe case of hyponatremia, we need to give the patient at least 3% of hypertonic saline or saline, 100 ml intravenous over 10 minutes. And we need to repeat this if needed according to the circulatory status of the patient. How do you achieve that? We have to set a goal. We need to raise the sodium by at least 4, 5 or 6 milliequivalents quickly and then stop. Here, hyponatremia has to be corrected as soon as possible, ASAP. But remember that hypernatremia does not need to be corrected as soon as possible. Hyponatremia needs to be corrected as soon as possible by giving hypertonic saline, that is 3% NS over 10 minutes, 100 ml of 3% LS over 10 minutes, and we need to check the sodium levels. We need to raise sodium. Suppose it is 135. We need to raise that 135. Suppose it is 130. We need to raise that 130 to 135 in 130 to 135 within 10 minutes, 15 minutes only. And we have to check sodium levels and then stop giving hypertonic saline. If there are no severe symptoms, if the symptoms are very severe, like they are in coma and seizures, this treatment is valid. If there are no severe symptoms, then we should consider the 3 groups that we discussed earlier, that is hypovolemic, euvolemic or hypervolemic hyponatremia. So in case of a hypovolemic hyponatremia, we just need to give normal saline, that is 0.9% of NS. In euvolemic hyponatremia, that is in the case of SIADH, where the brain is producing more amount of ADH hormone, we need to actually restrict fluids because it's euvolemia. The volume of the water is normal in such patients. And in cases of hypervolemic hyponatremia, we need to give salt and fluid both restrictions and treat the underlying cause. What are the underlying cause? Heart failure, congestive heart failure, then cirrhosis, and any tumors. What was those? Yes, high nephrotic syndrome. These are the three things that we need to treat first to treat hypervolemic hyponatremia. All right. And now coming on to, yeah, if the patient's symptoms are not severe, we need to understand that we are not supposed to correct the symptoms fast or correct the sodium dyselectrolytemia fast, because rising, but if we raise the sodium by we have to just raise the sodium by no more than 8 milliequivalents per day. So suppose the patient comes today is 17th October, and if you start raising that sodium in the entire day, that is now it is almost 11 o'clock, so next day at 11 o'clock night we have time to correct sodium levels by only 8 milliequivalents. All right. Fast correction can cause ODS, that is osmotic demyelination syndrome, which in a simple words it will cause brain damage. Now this finishes off the treatment part as well as the discussion part of hyponatremia. Now we are discussing about hypernatremia. If you have any questions, please comment below. I'll try to take on the questions. कुछ comments आया क्या? कोई comment आया ही नहीं. Lower than the, we recommend that you stream at lower than the warning current bitrate is lower than the recommended bitrate. We recommend that you use a stream bitrate of 6800. Stream is healthy. अपन stream bit बढ़ा दे क्या? Stream bit कैसे बढ़ाते हैं? स्ट्रीमिंग का बिट रेट नहीं बढ़ा सकते भाई. आई कैन नॉट. बढ़ा सकते हैं क्या? वेरिएबल बिट रेट डाला है. नहीं भाई, ऐसा कैसा हो गया ये? स्ट्रीमिंग बिट रेट इज़ गुड इनफ. रिकॉर्डिंग बिट रेट इज़ वेरिएबल. ये वेरिएबल है, ठीक है. मैक्सिमम बिट रेट बोला है क्या? बढ़ाते ना फिर भाई इसको. मैक्सिमम बिट रेट इज़ 50,000 करते ना. 50,000 50 50,000 करते. बढ़ा है क्या मैक्सिमम बिट रेट? मैक्सिमम बिट रेट बढ़ा देते हैं. सॉरी फॉर डिस्टर्बेंस. आई नीड टू फर्स्ट चेक because the stream is not acting healthy. That is what YouTube has told me. I hope you are hearing properly. Hmm. 20,000 करते हैं कंप्लीट. 20,000 हो गया तो बस हो गया. ओके, अप्लाई. यस, अप्लाई. ठीक है, चलो. सो कमिंग बैक टू hypernatremia. Hypernatremia suggests, what does hypernatremia mean? Hypernatremia means high sodium levels in our circulation. So what are the causes? Think of water loss or too much salt. Hypernatremia means water loss हुआ है and too much salt has been retained or has been intaken. What are the types? Whether it is water loss or sodium gain. What is the cause of water loss? It might be fever, it might be sweating, it might be diarrhea, or it might be diabetes insipidus. So भी थोड़ा पानी देना. Then second is sodium gain. what does thanda pani? Sodium gain. Thank you. Sodium gain because of too much saline. I am live. You can watch my channel. Not here, in your video. Abhijit Kirtane MD. Okay. So water loss because of fever, or maybe because of sweating, diarrhea, diabetes insipidus. Whereas sodium gain may be because of too much saline, that means you have taken lot of salt poisoning, or hyperaldosteronism. Aldosterone is a hormone which restricts sodium loss from our kidneys. So hyperaldosteronism, that means aldosterone hormone itself is produced in a larger quantity, and because by virtue of this aldosterone restricting sodium loss from the kidneys, sodium is retained in the kidneys, which causes sodium gain in the system. So what are the symptoms? Again, these will be CNS kind of symptoms, because I have told you sodium CNS. So symptoms will be thirst, dry mouth, confusion, CNS, irritability, CNS, seizures or coma if severe, again CNS. So that's why I have written sodium is equal to CNS. All right. Why do these symptoms happen? Because brain cells, they shrink when water leaves them. This is hypernatremia, where water is lost. So water is leaving the brain cells and the brain cells are shrinking, and that is causing all these kind of symptoms like confusion, irritability, seizures and coma. What are the diagnostic steps? First, we need to check the hydration status of the patient. We need to first examine whether the patient is outputting or whether the patient is passing urine normally or no. We'll have to check the urine output as well as the urine's concentration. How concentrated the urine is, that is called as osmolality. If the urine is very dilute, kidneys can't concentrate. If the urine is very dilute, that means it suggests that the kidneys cannot concentrate urine. That means it suggests there is some problem over here or in the kidneys. There are two types of diabetes insipidus. One is central diabetes insipidus, that is CDI, and nephrogenic diabetes insipidus, that is NDI. All right, where the kidneys are the problem, the receptors are the problem. So look for sources. Third is look for sources of water loss or sodium gain. You have to find out the sources, or you have to find out what is causing the sodium to gain in our body. So this is to be found out. And how do we treat it? Now, treatment is first line and second line. First, if the patient is in shock, then we need to give normal saline and restore blood pressure. All right. If the patient is not in shock, or the the next step would be we need to replace water slowly using 5% dextrose or oral water. So first step is to give normal saline 0.9% NS and restore the blood pressure which has gone down or which has gone up, and then we have to replace water slowly using 5% dextrose water, D5W बोलते हैं उसको, or oral water. If the patient is stable, you can give oral water as well, D5. Formula for what is the formula for water? You have to find out the water deficit of the patient. So what is the formula for water deficit? The formula for water deficit is 0.6 into body weight in kilos into sodium by 140, because 140 milliequivalent is supposed to be taken as normal, minus 1. For example, if the patient or a person is 70 kilos and sodium is 160, that is hypernatremia, it is more than 145. So we will find out 0.6 into 70, that is body weight, into sodium that is the serum sodium of that patient, that is 160 upon 140 minus 1. So that comes to be to around 6 liters of water deficit. So 6 liters of water deficit has to be corrected over 2 or 3 days. Max 3 days is the best, because 6, that means 2 2 2 2 liters per day. You can replace this water deficit over 2 to 3 days, not all at one time. If you correct this water deficit, what will happen? The water will seep into the brain cells, the brain cells will swell and they will rupture, and that itself will cause seizures, coma, and all brain damage. Alright. So we now come to the comparison table of sodium as well as hyponatremia and hypernatremia, and looking at the main points. Serum sodium is less than 135 in a case of hyponatremia, and it is more than 145 in a case of hypernatremia. Whereas the main problem is in hyponatremia, too much water intake has happened, whereas in hypernatremia, too much water has been lost out of the system. Brain effect is hyponatremia will cause brain swelling, whereas in hypernatremia, the brain will shrink. Why hyponatremia will cause brain swelling? Because water has seeped into the brain, whereas in hypernatremia, too little water is there in the brain, so the brain cells will shrink because of water loss. What are the main symptoms? Both confusion, CNS symptoms like confusion, irritation, seizures, coma, and confusion. These are the symptoms for both hypo and hypernatremia. And dangerous complication might be, for hyponatremia it is ODS, that is osmotic demyelination, whereas in hypernatremia it will be cerebral edema. Alright, because of correction. The complication is because of the treatment. It is the complication of over treatment. Alright, if you over treat, you treat it very fast, then these are the complications that might occur in the case of hypo or hypernatremia. What is the correction rule for hyponatremia? We need not correct more than 8 milliequivalents per liter per day in hyponatremia, whereas in hypernatremia we need not correct more than 12 milliequivalents per liter per day. Alright. Also remember that water deficit has to be corrected within 2 or 3 days maximum. We cannot be fast, because otherwise it will cause rupture of the brain cells. Now coming back and revising and summarizing all the lectures, everything that has been taught in this lecture, we need to know that sodium reflects water balance. Water is equal to sodium, sodium is equal to water, but not just salt balance. Sodium reflects water balance, not just salt balance. It is not just salt, but it also reflects the water level of our body. Always check volume status, whether it is hypovolemia, euvolemia, or hypervolemia. Then in emergencies, that is in the case of seizure or coma, you need to use 3% saline for low sodium. Alright, and we need to correct sodium slowly and carefully. Never be in a rush to correct sodium, because it is going to cause brain damage, either by ODS or either by cerebral edema. Alright, we need to monitor sodium every 2 to 4 hours while we are treating such cases, and beware of ODS if hyponatremia is corrected too fast. I have again reiterated this very important point earlier. In hypernatremia, correct gradually to avoid brain swelling. Alright, then we'll discuss mini cases and finish this lecture, round it up for tonight. Case 1 is patient with vomiting, low blood pressure, dry mouth, and sodium is 120. Sodium 120 है, ड्राई माउथ है एंड वॉमिटिंग है, hyponatremia clear cut case. Okay, because the patient has dry mouth, that means volume has gone down. So this is a case of hypovolemic hyponatremia. What do you do? What do you need to do? Simple, plain simple 0.9% normal saline or saline according to the area where you live. Okay. Second case, a patient with lung cancer is an elderly patient with lung cancer. There is no edema, euvolemic, no edema. Sodium is 118, that means hyponatremia, and urine osmolarity is high. Why? Why? It is because SIADH. SIADH is syndrome of inappropriately excessive ADH, which is not produced in the brain. It is produced somewhere else. The kicker is lung cancer. And lung cancer, if you know, produces certain types of lung cancer produce ADH hormone. So that's why it is a case of SIADH, and we need to restrict fluid. Alright, because ADH is already secreted in excess. So fluid और ज़्यादा conserve हो रहा है. Fluid is retained. The fluid is retained by the kidneys. So you do not have to give fluid. You have to give only the basal or the body mass index use करके body surface area use करके जो maintenance fluid है ना उतना ही आपको देना है. And if the third and the last case is if the patient is a poor patient, dilapidated building में रह रहा है, एकदम malnourished patient है, having fever, having poor intake, and sodium is 155 sodium, more than 145, that itself suggests hypernatremia. Then a patient having fever and intake भी नहीं है, मतलब hypovolemic hypernatremia, that itself suggests it is dehydration, hypernatremia, and we'll have to give rehydration but with slow D5W, that is dextrose water दे के उसको rehydrate करना है. And with that said, guys, we end this video and the lecture on dyselectrolytemia, especially hyper and hyponatremia. I hope you understood. If you have not understood, please comment down below. I will try to make it more elaborative, make it more simpler in the next video. Till next time, adios, tata, bye bye, good night.